The broadcast is now starting. All attendees are in listen-only mode.
Hello again, everyone, and welcome to this installment of the Practice Perfection Web-Based Education Series. I'm Danny Bobrow, President of AIM Dental Marketing, fresh off our September break to attend the third annual session of the American Academy for Oral Systemic Health, as well as convene our 16th annual Climb for a Cause event in Taos, New Mexico. We are excited and fortunate to be back with you today, hosting a world-renowned speaker who is actually connecting with us today all the way from Cape Town, South Africa. Dr. Julian Holmes is a 1985 graduate of the UK's Sheffield Medical and Dental School, Sheffield University. Prior to joining as a partner in a private practice outside London, he worked in Spain and Gibraltar, and then, in 1997, set up his own dental practice to deliver cosmetic and implant dental care. He has lectured in the U.S., Canada, Europe, South Africa, Australia, and Asia on implants, the World Wide Web, and, of course, ozone. In 2003, he sold his practice to concentrate on ozone research in Ireland, along with Professor Edward Lynch. He developed ozone treatment protocols for Cavo, Ozecure, Lyme Technologies, and GCE. He left dental practice in 2004 to launch healthcare and ozone-related companies and products. In fact, a new product launch is scheduled for later this year in Australia, and I'm sure Julian will have more to say about that later in today's presentation, which is a very exciting development indeed. Today, Julian will share his journey from a demolition dentist through minimally invasive dentistry and on to herpes and HIV infection research and possible cures. Today's event is set to run for 90 minutes. Feel free at any time to submit your questions using the question button on your screen. As usual, we will do our best to get to all your questions following Julian's presentation. If we should be unable to do that, Julian will respond personally to your question following the presentation. This webcast is being recorded, and you will receive a link to it soon. Now, in working with Julian on this project, we soon realized that there was simply no way we could do justice to what is typically a two-day presentation in the time allotted, and so Julian has most generously offered to share as a link the slides which comprise his entire two-day presentation. Details on how to receive the slide deck will be shared following today's talk, so if you like what you hear and see today, you're going to absolutely love the rest. Also, information on how to receive your continuing education credit will be shared upon the conclusion of Dr. Holmes' talk today, which, because of the additional material being offered, amounts to a full 6 hours of CE credit available. Basically 4 times the usual, so you're getting a 4-for-1 today, folks. My business and life partner, Virginia Norton, will present today's attendee poll, as well as field your questions during the presentation. And now it is my distinct honor and privilege to introduce to you all Dr. Julian Holmes. Hello, Julian.
Hi, Danny, and thank you very much for a very kind and a very generous introduction. For that, I really do thank you. I probably don't deserve all the accolades, but nonetheless, thank you. It's been, I just find it quite awesome that we are something like 7,500 miles away and sitting on the bottom of the world. And contrary to popular belief, you don't fall off. But it has been the most beautiful spring day here. So, say again, Daddy?
I'm happy to hear that, sir. I'm sorry that you're missing it, but I'm sure there'll be others.
No, not to worry. This is what I do. So what I'm going to say to all of you who are listening, please don't take notes. Just listen, notice the slides. The slides are going to be available with the 6-hour CPD. And as we go through the presentation, and as we get towards the end, there are going to be special offers on the CMU4, which is the new unit which we're launching, and some of the other technologies, and of course the ozonated plant oil. So this is really how I started dentistry as a demolition dentist. And in line with most technologies, it's great when it works, and it's superbly awful when it doesn't. So let me just click this. There we go. Drill them, fill them, kill them. This is how I started dentistry. And back in '85, when I qualified, this is what I was qualified to do. I saw lots of patients where we had large holes like this, and I had no idea when I first qualified that holes and cavities in teeth were linked to these little suckers, which are the HPV and the herpes virus. Neither did I have any idea that gum disease is also linked to these little suckers, which, and you see these little blue dots here, which you can see with my arrow on the mouse. This is HIV. And so when I first qualified, I was raw and very wet behind the ears. Now I'm old and gray and I'm losing my hair, but I have a greater understanding that we shouldn't be focusing on 32 plus 20 teeth. What we should be focusing on is the total care and the total health of our patients. All our patients enter into this sort of cycle. So we have a cycle from a small area of decay into a large cavity. And I'll share with you what happens in this cycle, because it is fundamental to our understanding of how the whole of the system works.
And Julian, before we continue, why don't we just find out where people are at in terms of their understanding of the topic, and as we often like to do, poll our audience and see where they're at. So, Virginia, if you would be so kind as to show our attendees the first question. And that question is, do you use ozone therapy in your practice today? We'll just give you a moment to answer that, either yes or no, and see where we are. Okay, that was a pretty simple question, so I think everybody should have had time to answer that. And let's see what we find. So we're showing actually, I'm not too surprised by this, Julian. The 40% of our attendees are users of ozone. 60% are not. But boy, if you compare that to the population in general, we're very well represented by people who obviously already get the importance and value of this.
Yes, and that's very gratifying to know as well. So it's an interesting poll and a useful one. So I have a really good idea of where to aim some of the questions and also some of the information. So I'd like to thank our 28 attendees for pressing their respective buttons and just giving me an idea of sort of really where we are right at this minute.
Now let's drill down just a little bit deeper. Sorry.
Press show my screen again because we're not seeing your screen, Julian. There we go. Thank you.
Okay.
Perfect. Okay. So as I was saying, let's just drill down a little bit deeper to, and that's the only use of the drill today. I promise you, folks. For our second polling question, and that question is: if you have heard about ozone but don't use it, basically, why not? Is there a perception about the cost of entry? Is it beyond your comfort zone, or perhaps are both of those reasons responsible? And we only had 65% of the attendees vote, so let's see if we can get that up a little bit and see what we come up with. We'll give you a little bit more time.
I think the results of this particular question, Danny, are going to be the most interesting.
Mm-hmm. It's interesting, indeed, that 57% respond that it's beyond their comfort zone. Or, I'm sorry, that it's the cost of entry. Nobody feels that it's out of their comfort zone, but some people feel that it's both. Very interesting. So, if you know, what I interpret or infer from this is, if you're concerned about anything, you're concerned about both, which I believe is understandable. So again, just Julian, because I know you don't see the results. It's 50%
on that one. Yeah.
Okay. Wonderful.
Yeah. I hope that also the people will send in questions as well as to what is actually keeping them out out of the, if you like, the ozone treatment. So that if they have a more general comment to make, then please, as an audience, please send those comments in, and then we can look at that for maybe something in the future, or maybe if we get time, we can actually answer that question for you towards the end of this presentation.
Absolutely, excellent point. If you want to share with us why you're uncomfortable, please do. And if Dr. Holmes doesn't address that in his presentation, he can do so in the Q&A. And then our final question: have you read about the use of ozone and ozonated oils in periodontal care? And the votes are just about in. All right. And what we're showing is that 61% have, 39% haven't. Sounds like we've got good news for a third, and probably more to share with the two-thirds who already at least have heard about it.
Absolutely, yeah. No,
great.
Great questions, Danny. Thank you for those. And also thank you, audience, for sending those answers in, because it's really helpful as a presenter or as a lecturer to know where the audience is coming from, because I can spend a little more time on some of the research which shows how effective these particular products are for you.
Absolutely. Are we good to continue then?
Are we ready to go? I'm just waiting.
Yep, I think we need to just close. We need to close the poll.
Yeah, I did close that. Okay,
there
we
go.
Okay, there we go.
All right.
Perfect. So, as I was saying earlier, this is a cycle from small areas of decay growing through to large areas of decay. And later in the presentation, there's a small piece which I wrote in about 2003, 2004, which became part of the ozone revolution in the Quintessence book, which basically says once you have a patient in this cycle of decay, it's very difficult, if not impossible, to return them back to like full health. You should really view bacteria as very complex communities, and there's quite a bit of time delay between South Africa and the States. So here you go. So now you can see a picture representing what bacteria look like. It's a very complex community. It is a small city all within itself. And lo and behold, it's not just in your patient's teeth, but it's probably in your teeth as well. And when you start to examine these communities, you actually start to understand how complex treating these areas of decay is. So many of you will have seen cases like the one which is just about to come up on your screen, where you had a patient who's come in pain, and you start to look at x-rays, and then when you start to take teeth out, you see these amazing areas of infection which come out with them. And if you start to examine the bacteria which are present in these small abscesses, you start to realize that there is no way that this patient can function and live with this degree of infection in place without other consequences to the rest of the patient's body. We're talking about, tonight, ozone and the role that it has in general health. Ozone, as most of you know, is three atoms of oxygen. It's represented in different ways, as you can see on the screen. The one which I prefer, I think, is probably the one on the extreme right, because it gives you a very good graphical representation of how it works and how it interacts. But its effect on teeth is incredibly profound. So in the slide which is now on your screen, on slide number 2, or the picture number 2, this is pre-treatment. The tooth has been dried. It has this dull acid-etch appearance. And that is indicative that there's a high level of active decay. In fact, it's an acid-niche environment. And yet the same tooth on slide 8 has been treated just with 40 seconds of ozone. And here we're seeing the patient 2 to 3 months later. This surface now completely glassy and inert. that will never ever decay. And so my questions to you really are, is there a need, or is there a real need to actually restore that tooth, apart from the cosmetic surface? But from a functional point of view, probably not. We know these teeth are going to drop out. And from a functional tooth as far as eating, this patient is going to eat quite happily. So we're going to chat a little bit now about the history of ozone, and the slide which is just about to pop up is, of course, the London Underground. And here you see the London Underground in all its glory and its rushing past. And yet by 1904, 1905, the whole of the London Underground was actually being treated with ozone gas. The Victorians understood that public places were immense areas of potential cross-infection. And what better to actually counter the infection than to actually introduce ozone. When we start to look at teeth, the effects are even more profound. So here we see on the left-hand screen, you can see the area of infection, which has got the red arrow. 3 months later, after ozone treatment, you can see that white crescent of remineralization. And what's happened is minerals, both from the nerve tissue, which has remained alive, it hasn't died as most people would have thought on the left-hand side. The nerve tissue has supplied minerals and fluids, and from the oral cavity, we supplied a better environment plus some remineralizing solutions, and we can actually get the teeth to heal themselves. And we're not talking about healing in the sense of a complete crown becoming whole again. There's still going to be a hole there, but we're talking in terms of healing where there is no infection left. So ozone allows us to treat small children. So this is Danny. He is actually a 4-year-old. He's scared absolute shitless dentist because he's had horrible experiences in the past. And yet for Danny, we can pop him in a chair with no drills, with no anesthetics. It's 40 seconds of ozone in slides 1 and 3, and then we put Fuji's triage, which is got high mineral content in. So in 4 and 6, you can see the 2 restored teeth, and the whole process takes about 60 to 70 seconds. It's really quick, it's fantastically easy, and you build patients' confidence with it. Some of the later research, which I'll go through with you, is looking at the role of plant oils. Plant oils are very susceptible to taking up ozone, and here's the products that 1 or 2 of you will be familiar with. This is LSO3, which is the linseed oil, which has been treated with ozone. And then on the right-hand part of the picture, we've mixed this linseed oil as a 50-50 mix into a lip-filled type delivery system, and the beeswax hardens it so that you have a semi-solid which you can take and put in your purse. So you're not going to get free oil messing around with all your important documents. And of course, if we use these sort of fluids, now we actually cross over from dentistry into general health, because now we can actually start to heal. And the slide which is about to come up on your screen, you're going to see bed sores on a retired dentist's heel. He wasn't turned correctly. He formed these sores, but just at 3 months, we've got complete closure on one side and new granulation tissue on the other, where previously they've spent somewhere around about 12 months just dressing them with traditional dressings and not getting anywhere in particular. So these particular types of fluids can have profound effects on healing, but also we can move it on to another dimension too. MRSA is the superbug of note. It basically eats people alive, and once people are infected, it is incredibly difficult to get it out of the system. You know, if you like, as a physician or as a clinician, I send my patients to hospital to get well. Sadly now, if we send our patients to hospitals, they'll probably come out with MRSA as a superbug infection. And this young lady decided that she didn't want the large tattoo on her back. I saw her on the slide which is called July 2008. And if you look at the way she's holding herself, she's holding her shoulders absolutely rigid because she's in pain. And yet in 3 months, so we've got from July the whole way across to October, there's no skin grafting here. We have cleaned the wound, we've sterilized it, we've encouraged tissue regeneration, and we have new tissue which is forming And so this patient now, you can see her shoulders are much more relaxed. She's out of pain. And when I reviewed her a couple of months ago, she has a little bit of photosensitivity. That's without any skin grafting. It's purely ozone treatment and with some specialized skin gel. So how do we move from there to herpes? Well, as I'll show you later on in the presentation, herpes and its relatives, if you like, HIV, which is all part of a virus group, they are very susceptible to ozone degradation in such a way that you can actually take patients from being very ill, being patients who are no longer moribund, and they become useful members of society. The problem we have is that medicine, even though they're great at publishing papers, as dentists, we don't tend to read them very often. And so one of the real problems that we face in clinical care is if we don't read the papers from outside our 32 teeth plus 20 deciduous teeth, we tend to lose out on what is actually happening in other people's professions. The new research, well, the research which I'll share with you a little bit later in the presentation, is such that we actually know that this research links herpes and HIV viruses and HPV viruses to general health all comes from the oral cavity, and the research was published in the late 70s and 80s, which I find disturbing because we have a group of patients who come to see us every day for periodontal work, and yet the periodontal work is absolutely key in actually making sure these guys go away alive and stay alive. And we can actually, we're in an incredibly special point of time and space where we actually have an opportunity to influence how people's lives will pan out over a long period of time. Because these diseases are now linked to Alzheimer's and what will be termed the aging population degenerative diseases. On screen now, you can see some of the results that we've had just using ozone and ozonated oil. So in the light blue, this is before, the purple is after. You can see we've got an incredible increase in the T4 cell count, so the patient is getting better, and viral loading has dropped somewhere between 15 and 20%. The case right at the end on patient number 11, I'll talk to you about her because she's a very interesting and very special case. The presentation about how we actually deliver these new products to the patient. It is basically a 1 ml filled cellulose capsule. They can be taken orally, or you can use them as a vaginal or as an anal suppository. And for those of you who are beginning to feel a little bit squeamish because this is not something potentially you're going to do in your dental chair, you don't have to do it. You don't have to take your practice to this sort of level. But there are ways of incorporating this knowledge in how you're going to treat your patients. So in many ways, I've taken you through a very short sort of introduction of, we start off as the general dentist who destroys, cuts teeth, amputates it, and it's death and the gas, all these bugs. We deal with open cavities, and then really what I'm showing you on the screen is these are some of the delivery systems for ozone, and where we can deliver it to pinpoint accuracy in the lower right slide, or we can put the whole body, excluding the patient's head, into a canister. Put it with ozone, and then we start to get the most amazing results, because now we're actually treating the whole body rather than just one individual component. And certainly you'll hear me developing the argument as we go through the presentation that we need to move away from this tunnel vision of 32 teeth plus 20, and we need to look at the whole patient in a more holistic way, because we are dealing with patient populations now rather than individual people. So let's get on with the main teaching part. The slides are not particularly pretty. It's lots of if you like, words. So listen to the message. Don't take notes because we're going to get this all later. So I assume that you've all passed your exam. It's basically how we move from being like a student to a clinician, and how we actually get our knowledge. And I'm going to encourage you and actually demand that you're critical, because over this next few minutes, I want you to be critical of the presentation. Ask questions, please, because that way, we all learn. I certainly believe that we are through the days of watch and wait, and the days of tissue amputation are long over. And for those of you who do lots of cosmetic work, yes, it is a patient's choice to have their teeth destroyed, and you put new crowns and whatever on them. I don't believe it's a particularly holistic way to treat patients, but you know what? It's down to patient's choice. But I do believe we are moving away from sort of watch and wait and amputation. When we actually see small white areas on teeth, and we can actually tell the patient exactly what's going on. I would say that in the majority of practices, the patients are told, well, let's see what it looks like in 6 months, 5 months, 10 months, 12 months, whatever. For the vast majority, there'll be no change, but for quite a few, there's going to be a surprisingly large hole which they can climb into. And so the failure to diagnose with modern technology really is inexcusable. There is absolutely no way that you should be missing this sort of this diagnosis, because we have a lot of systems which are available to us to make these diagnoses. I'm going to chat a little bit about the International Association for Ozone in Healthcare and Dentistry, because we have very specific aims, and part of it is scientific meetings, but it's also education. And we are training students to go out and treat patients holistically with ozone. And I guess the real difference I see between medicine and dentistry is that when a patient goes to see a medical doctor, there is absolutely no expectation that the infected finger they've walked in with is going to be cut off. But in dentistry, that's exactly what the expectation is still. Because if they have a hole, they know that the dentist is going to drill it, we're going to amputate it, or potentially we're going to take it out. And it's really, how do we get across to our profession that you don't have to do that life is changing and that the treatment is changing. So I'm going to split up treatment with ozone into 2 main areas, one with ozone with gas and one with ozone which are the use with treated liquids. So let's look at the ozone with gas first. We know that ozone is a very common molecule, and it's basically it's a polymer of oxygen, which is the 3rd most abundant element and forms 21% of the air we breathe. You shouldn't call it activated oxygen. Ozone is not activated oxygen. Activated oxygen is O-, which is a free radical. So I'd really like you to move away from some of the misnomers which we have surrounding ozone. It's also not dangerous. I mean, the FDA has this wonderful spokesperson who a couple of years ago said ozone has absolutely no use whatsoever, and it is the most dangerous chemical and has no place in clinical work. I'm sorry, but I really don't agree with him, and neither would thousands and thousands and thousands of patients who from 1885 were being treated with ozone. They would not agree with him. And in terms of clinical use also would encompass manufacturing clean water for him to drink. And what he doesn't realize is probably the water he drinks in the city that he lives in is all being treated with ozone. The watch he's wearing on his hand, if it's electronic, that's the PCBs inside, they would have been treated with ozone to clean them. And the pop cans of Coca-Cola and whatever other carbonated drinks, that has all been treated with ozone as well. One of the reasons which we are moving away really from ozone generated with air is because air has nitrogen. Nitrogen compounds are not particularly healthy, but in its use in dentistry, where you're doing a surface application to a tooth, the nitrogen compounds do add to the kill. So that if you have a lot of bacteria and you have very deep areas of decay, the nitrogen compounds will eliminate most of the, well, in fact, they will eliminate all the bacteria and viruses and fungi that grow. Okay, you've probably noticed that I'm talking a lot, which is not unusual for me, and the presentation is going a little slower. There's quite a large lag time from what shows on my screen here to what I see that you're watching. So forgive me if you think I'm sort of bumbling a little bit, but we've got to cope with 7,500 miles of getting these electronic signals up to you. One really interesting bit which I came across purely by accident when I was doing some of my initial research back in 2001, 2002, was this a piece of equipment which showed that from the Locomotive News and Railway Contractor in 1937. And this is really where the history of ozone in its use in public areas comes from. And we've moved on now. This is the picture of the new CMU4. It's predictable healing. This is what we're after. And what I can actually share with you is that if you use these tools as they've been designed, and if you use the protocols which I've designed to go with them, and with the Ozone, which was made by Tavo, and the CMU3, which was made by Lime Technologies and also Grow Cells, and the Ozone, which was part of that whole fold of different equipment, plus the RAS, which is a room air sanitizer, Mark 1 and 2. If you use them as they've designed, you will get exactly the same results as I get either in my rooms or in the areas which we use these machines or in the treatments which I'm proposing. So let's just have a quick look at what the FDA says about its own drugs. There are over 120,000 people die from prescription drugs misuse. There were 6 million ozone treatments in 78 carried out from German reports, and there were 3 side effects. And nobody has ever died from ozone treatment. I mean, it is amazing that people still want to try and tell you that you shouldn't use ozone. And I cannot answer the question as to why they feel it's so important or why it's so dangerous that you shouldn't use this in practice. But what I can share with you is that in 2002, this group of researchers, Dunn, Wentworth, Petrucci, Jones, and Janda, they showed in 2002 that your own white cells actually produce ozone as part of your immune system. And it's your antibodies or your white cells that circulate around your body are happily producing ozone, which is then converted into hydrogen peroxide. And that's how the human neutrophil, or the human white cell, actually combats disease. It's amazing, isn't it? Here we have the most elegant system, which is actually part of our system, part of our bodies, and we're actually using ozone. So I still don't quite understand why the FDA has a problem with ozone, because it's a natural product. Bacteria, they've been around for millions and millions of years. They produce these most amazing and very complex communities. They have nutrient pathways, and they send biological signals to other bacterial types. And when you start to look at that picture which I showed you of the tooth with that wonderful city inside it, that's the sort of community which we're actually looking at. So we have bacteria that exhibit neutral independence. They have an acid niche which evolved from being alkaline to acidic. You have these, the idea that you take one bacteria out and the whole thing collapses. That doesn't happen because the bacteria re-engineer themselves so that they can actually take account for it. So if we regard caries or decay as a simple infection, it is an infection, but it's not simple. In the old days, we used to put things under microscope. Now we're a little bit more, we have a lot of technology. So what you're looking at here is the old way of looking at bacteria, which is down a microscope, to the new way of looking what happens to bacteria, and this is called HMNR. It's a very elegant research tool, and it allows us to do these sort of tests. So coming up on screen, you're going to see a specimen of a decay from a root biopsy, root dentin biopsy. This is what it looks like from a chemical point of view. And there's the tyrosine, the pyruvates, the lactic acids, and somewhere down here you can see there's a little bit of methanol down here, so we actually know the patient had a drink, possibly Guinness or whatever. And yet when you actually start to look at this, this is what you see. Now let's expose that to ozone. So when you just underneath there, now you can see all those spikes have gone. This is the effect of ozone. Ozone has taken this whole complete spectrum of acids and bacterial byproducts. The whole spectrum has been ozone treated. It has been oxidized. You have acetate acid, which is this huge spike here. Acetate acid has a pH of about 6, 6.5. So what we actually see now is the acid-based lesion turns into a basic lesion. Minerals can actually start to flow back into the tooth. So that's why ozone treatment, if you choose your cases carefully and you select those cases and prepare them correctly, it is probably the most elegant way of showing patients what modern healthcare is all about. It's scientific, it's advanced, and it really does work. And when I published this in 78, this is what we were seeing. Progression is acidic. Reversal is going towards hard. So we've got mineral uptake and the acid niche environment. So the key to this, the key to caries reversal is eliminate the bacteria, eliminate the acid niche environment, eliminate all those biomolecules, change it from an acid environment into a basic environment, and then with the change in pH, you'll get minerals will actually flow into the tooth rather than minerals being lost and the lesion expanding. So there is now, I hope that we're laying to rest this difference between medicine and dentistry, where we can change patients' expectations, where we don't actually have to cut holes, we don't have to drill huge areas of the tooth away. So the slide which is on its way to you now, you're going to see a molar tooth which has been diagnosed as having decay. It's dull, it's leathery, that's active decay. And here we have on the right tooth, which is the same tooth which has been treated with ozone, which is now shiny, it's healthy, it's hard, it's remineralized. There is no longer a need to put a filling in there, apart from those of you who like form and function and those of you who don't like holes, because that area is never going to decay again. And the secret to ozone is that once it becomes this glassy matrix, the bugs can't get in, the decay process can't stop. Sorry, the decay process can't start again. We had, certainly in the early days of when we were trying to figure out how far could we actually push this research, we had our fair share of failures. And Charlotte, who was 12, she had an interesting medical condition which meant that you couldn't put local anesthetic into her mouth because the needle tract, as it cut, would cause internal bleeding and she would probably die. So she's got a really low platelet count. You can't stick needles into her, but she's got a need for treatment. So how are we going to get around it? So you'll see the X-rays that are about to pop up on your screen. You've got the right-hand side and left-hand side. And my apologies, I'm not quite sure what I've done there. There we go. On the, it's okay, those X-rays are about to come back to you. On the patient's left, where it says, where you see the 6 and the 7, you'll see interesting shadows just underneath the tooth. Here you go. You can see the shadow here, and there's no shadow here. But if we actually look on the patient's right, which is here, this is where we started from, little hole, and now you can see we've got a massive problem. And this probably gave us the clues as to why ozone needs, or why teeth actually do need some preparation. So we haven't entirely escaped from the amputation bit, but we are now into limited amputation or the concept of minimal invasive dentistry. So on this side, all we did was we cleaned the fissures out with air abrasion, we ozone treated them, and then here is the result. We have lesion hardening. If we contrast that with the other side, you can actually see the lesion now as I've ringed it, and it's about to pop up on your screen. It's almost as bad, isn't it, Danny, where we were having lots of echo in the when we were setting this up. Now we've got this sort of time lag with these pictures as they come up. But it's a good pointer for me. Next time it's going to be very simple graphics. Otherwise it's going to, yeah, here we go. You can see right in the middle of this tooth. Here's the
Julian?
organic plug. Yeah?
I'm not sure that this will help. I'm seeing that you're using, the screen and clicking on the right arrow that's part of the presentation. Sometimes for me, if I push the actual down arrow key on my keyboard, it advances. I don't know if it'll help or not, but thought I'd put it out there.
I tried that, and it
Okay.
didn't want to work very well. But there you go. And sometimes it works, and sometimes it wasn't working for me down here. So I decided to sort of drop that one and just go for the arrow at the bottom. But we'll try it and see how we go. So
We're doing fine, thanks.
If I take you back to why did we get the poor results? Well, the poor results are because we didn't actually understand what fissures look like. Fissures are not nice, clean fissures or cracks. They are dirty, infected, inverted bottle shapes, as you can see on the screen now. And what we failed to understand was that the organic plugs which form, the demineralizing zones and the mineral loss which occurs, all these add to an incredibly complex picture. And it's only by opening that fissure, opening up, cleaning it up, were we able to get the ozone actually into down the base of the fissure, in this part down here, right at the base. And unless you can get ozone there, then it's simply not going to work. And that was exactly what happened in Charlotte's case. So we know now we need to take away the organic plug. But if you don't do that, the ozone can't get in. If you look right down at the bottom, you can actually start to see these small cracks in the fissures, so that adds to the complexity. As you get demineralization, you get these areas of mineral loss right at the depth, and these soft areas, you simply can't get at that, and it's very difficult to actually measure it as well. And you're certainly not going to get a mirror and a probe into that area to actually look at it. And then you have demineralizing dentine actually underneath these areas which are completely undetectable. So these fissures are incredibly complex beasts to try and sort out. So we need a way of actually looking inside. And so how does it actually go from there? Well, now you've got the areas become demineralized, it undermines the enamel surface, and then you get this cavitation. And so the cavitation is here, it's represented by this large diamond shape, which is about to, here we go, it's building up in layers for you. There you go. You get this cavitation, and now you can actually start to see how complex it is. So now we've got visible caries, we've got the established acid-rich environment, we've got the mineral loss, and we've probably got pain as well. So for our accurate diagnosis, we know that we actually have to open these teeth up, we know that actually we have to look inside, and we have tools which allow us to do that. And without tools such as Diagnostic and some of the luminofluorescent systems, it's simply not possible to actually look at these teeth without doing mega dentistry. And you're probably not going to see this on X-ray. And the key really is, if you can spot it on X-ray, it's gone way beyond probably 3 to 4 millimeters into dentine. So it really is changing the way we sort of look at X-ray and also how we appreciate what we're seeing. So this is what ozone can do. There's a lot of things which ozone can't do. I used to have a slide that said ozone can't make you younger. Well, I'm going to start to disagree with myself, because some of the new research which is being shown, which has been coming to the fore, is that in the cosmetic industry, they're now using ozone injected in small areas, both to reduce fat and to tighten tissues. So really where we started in 2004 was looking at the reversal of occlusal stains and economic savings. We then started to look at atraumatic treatment and combination of therapies. We then started to look at having programs that actually work. If you get reversal, it's like, okay, how does ozone, or does ozone potentially interact with some of the materials which we're using? And some of these research studies are showing that you actually do get a greater bond strength. But, and the big but was, that a paper which was released in 2009 showed that if you were using a silane coupling agent ozone was probably degrading it. So for those of you who ozone treat and then you want to bond straight away, I would caution you against doing that, because if you're using silane coupling agents, ozone is going to degrade them. But you can use glass armors. I know glass armors are not particularly cool these days, and we've got these nano-filled particle materials and all the other things we can use, but the ozone doesn't do everything, and neither do the composites. And I'll share with you some research about composites that show that potentially we're putting another time bomb into our patients' mouths, quite apart from amalgam. But we can certainly use the use of either ozone dissolved in water or ozone dissolved in gas can be recommended as, if you like, a pre-treatment before your bonding procedures. There are ways of controlling the ozone gas there. Again, for those of you who download the presentation, you'll be able to see that. And then moving on to root caries, this is a study which I published in Gerontology, where we're using ozone in a double-blind randomized trial. We have fantastic results showing that we can actually reverse very simply. We then went on to show that ozone reduces the barriers to dental treatment and reduces barriers to care with patients managed with ozone in Italy. Then we had also studies coming out of Ireland and out of the north of England and the south of the UK. And then we had Danaher and a series of researchers from University of Bern showing that basically this is a non-invasive treatment and a real change, an alternative to drilling and filling. Because of the ability to actually eliminate the acid niche environment, it allowed us to do a lot more, a whole lot more for our patients. We weren't chasing our feet the whole time and watching these patients then decay again around new fillings. And so it actually made our predictability for having to replace these fillings much better. And instead of having maybe an 18-month cycle on certainly through the NHS, we were looking potentially at maybe a 5 or 6 year. So what I'm really saying to you is that ozone, or the original drill and fill application is poorly accepted by the public, which we know. The fillings which are put in place are usually executed very badly. There's always this increasing spiral of costs, and of course dentists, we make our own bad press. And so that really takes me on very neatly to this paper which I published in 2003. And what I said there is that the entry of a patient into the cycle of drill and fill is irreversible. Once that hole is drilled into a tooth, the patient is always going to have it. And you know, guys, you may think you're the best dentist in the world, but no matter how good a clinician each dentist, and that is me as well, perceives themselves to be, that restorative material will fail at some time. And so the key is all about prevention. And so some of the new research now is looking ahead to how can we prevent decay happening in the very first place? And how can we actually say to a patient, you know what, we have ways of looking inside this tooth, we have ways of actually looking on the surface of your teeth, or we can take a blood sample, or just a swab of saliva, and we can predict whether or not you're going to have decay in the future, or whether you're going to have heart disease, or whether you're going to be prone to periodontal. This is where medicine and this is where science is now blurring the edges, where we are moving out of dentistry from 32 plus 20 teeth, and we're actually looking at total body care. And one of the reasons why I threw my probes away a long time ago, you have a look at the end of what is actually a sharp probe, or be sharp to your finger and be sharp to this patient's gum if it were in place. The reason why we can't use it is because when you look at fissures, you have this bottle shape at the end, and there's no way which you can actually get a probe in there, and the mirror isn't going to see it. And so you're going to miss a huge amount of information, and really the only way which you're going to look inside this tooth and decide whether the stain is just the same or is it at the start of decay is if you're going to use a tool like the Diagnostic. And the Diagnostic is probably one of the best tools which you can use, and if you haven't got one, I would encourage you to go out and get one or get its equivalent, because it allows us to look ahead. We can actually do a very quick scan of a full patient's mouth in probably about 2 to 3 minutes. If you have software which you can correlate with what you're seeing on the diagram readout, and you can put that straight into your computer program. You can virtually predict. And so when we came up with this first concept that was called the Clinical Severity Index, we could actually say that if you were looking at something, say a value of 10, 15, we knew that it was just confined to enamel. When you're looking at something over in the 25 and 29, you're 4 to 3 millimeters maybe inside the tooth. And that's where we found that the research was starting to marry up between what we were seeing clinically to what we were seeing on a slide when you actually took a tooth, ground it into a little section, and had a look under a microscope. So that really simple clinical severity index, or the CSI, was then expanded into a much larger CSI. And the CSI now, which we developed in 2007, really is the simple guide to how to treat a tooth. If it has this value, this is what it actually means in the patient. This is how to prepare the tooth. This is how much ozone you put in. This is how to restore it. And you have to do multiple treatments. What really surprised us was some of the later researches, which was published in 2010, such as the Caries, was they got 41 patients got worse after ozone treatment. And the real question was, why did they get worse? And of course, it all goes back to Charlotte. Charlotte was the key. If you don't clean out these organic bloods, the ozone can't get in, therefore you still have this acid-base niche environment, and the bacteria will just keep on going. So understanding on the preparation is key to actually getting the results. And the poor results which came out in some of those papers over the last 2 to 3 years, because they didn't follow the protocols. They didn't actually understand what they were meant to be doing, prepare the tooth, and how to evaluate the tooth correctly.
So, Julian, if I could just request some clarification at this moment. I mean, what you're saying basically is that each of these areas is sort of its own microenvironment, and they've basically
Absolutely.
put up a nice little roof to keep everybody nice and cozy inside. And so the cleaners can't get in. And so the research that you did that showed that now you have a protocol that shows, given the degree of caries or the nature of the caries, that you have a specific protocol. I'm assuming that was not applied, and that was what was responsible for the lack of results in these patients. Is that correct?
It is correct. I mean, the problem we faced was we had a manufacturer who had some very elegant pieces of equipment. Their argument was they're not clinicians, which is quite right. They are suppliers of technology. So it came with very vague protocols and instructions for use. And the issues which we had with them was that, having shown them that if you followed their vague protocols, they were not going to get the similar results as we were getting in research. And Edward Lynch and myself spent about 2 years writing the protocols and touring around the various groups who we'd started off with ozone, showing them that the protocols do work, and the protocols are absolutely critical in the way that you assess each individual tooth, because each individual tooth has a different treatment need. The patient has a different set of treatment needs and expectations, and the dentist has a completely different set of expectations, because this is what has been told by the manufacturer. And what we were finding was that there was a disconnect, and we were attempting to put it back together again so that both the patient and the clinician and the manufacturers were all coming from the same point. And that probably was the hardest task that we had.
Mm-hmm. I imagine you're going to get to this, because it looks like on this slide already that ozone is in fact the solution to break through that barrier. But the fact that it wasn't working in the past means that there's going to be some specific ways in which you need to use it based on the type of decay or the extent of caries that present.
Yeah, okay. It was rolled out as a panacea, and it is, but there's a protocol with it. And if you don't follow the protocol, you're not going to get the same result. I mean, it's a very small digression, but we had a group of users in London who came to us and said, I've scanned the lesion with a diagnostic, and it says 99. I've treated them with ozone. I'm looking at them 2 months later, and it still says 99. You know, what's gone wrong because it hasn't worked? Well, there probably has been a change, but it shows a complete lack of knowledge of how the diagnosant works. The diagnosant only can read to 99. It physically doesn't have 3 digits on each side. So 99 is the biggest value. So possibly what they were measuring could have been 101 or 300 or 500.
Right. Sure.
In the treatment, they probably reduced it to maybe 150 or 125. But the diagram can only go to 99, so they're still not going to see the change. So that's where the foundation of our clinical knowledge is, what does it feel like? What does it look like when you drive? And you have to go back to your clinical basics and say, okay, we know there's a limitation, but the real limitation actually isn't one, because with our clinical experience and the way which we were taught dentistry when we were students, we dried, we popped in the probe. If it was sticky, we knew there was decay there. If it was glassy, it would glide across. When you dry it, it goes from, if it's still dull and looks at it, you know that that's an active lesion. If it's still shiny when you dry it, you know it's a piece of glass and it's remineralized. So it's learning how to use those clinical skills alongside the technology, which is key to, if you like, any aspect of medical or dental healthcare. And unless you put it together in that way, you're going to miss out on the essentials. And the essentials is, of course, that, you know, the diagnosant has a limitation. The limitation is that they only have 2 neurons, not 3. And they were probably seeing a change, but because they couldn't measure it, they assumed that it hadn't worked, which was actually probably incorrect. And so some of the research, you know, is showing that now, this is 2011, to 11, where ozone treatment, either with or combined with remineralized, with effective for remineralization of initial tissue caries. We showed that therapy has been more beneficial than present therapeutic modalities. i.e., ozone has a place to part, and this was a strategic review which was written. In the Lifeline, in the review of the literature, Prof. Burke came up with this most amazing review which he wrote, and he said, well, you know, I don't actually see any published papers which show that it's beneficial at all. And yet we know that Professor Burke, and even though I have a great deal of respect for him, he's never done any ozone studies himself. All he's done is reviewed the literature, and that he's reviewed it in such a way that it came out with a very negative impact. And yet that is not reflective of a vast, I would say, 99% of all the papers that have been published. We know that ozone is key to caries reversal. We know that ozone by itself doesn't cause remineralization. It sets up the biochemistry so that remineralization can occur. So ozone, if you like, is the key to caries reversal, not the causative agent of it. So sensitivity, some of the studies on sensitivity really showed us that if you use some of the new products like calcium sodium phosphosilicate, which you know better as Novomin. Novomin has to be, in my humble opinion, is probably the most advanced remineralizing agent which has been brought out. And if I was going to share with you what I felt were the most prestigious, or if you like, the most important advances in dental healthcare, Novomin would definitely be in one of them. Ozone would definitely be there. Air abrasion definitely would be there as well. And for some reason, there you go, and there you got it. Yeah, here's a paper which we showed where we were just using ozonated plant oils with Novomin, and with fantastic results. We're using now, in this particular study, and from 2011, again, they're using ozone gas as an adjunct with fluoride-containing desensitizers. And yet, you know, if you start to look at some of these studies, it said that they had no change to tooth hypersensitivity with ozone. Is like they didn't use the mineral wash, they didn't do the oral hygiene, they didn't give any diet advice. All of those items were part of the protocol. If you use the protocol, you get the effect. If you start messing around with the protocol, you're definitely not going to see the same results. And so, for those of you who now sort of would like to get involved in ozone, but you feel uncomfortable about some of the results that you've either read about, if you follow the protocols, you will get as good a result as we did in our research papers, or as I do when I'm actually treating my own patients. One thing which came up time and time again, which was, does ozone actually damage nerve tissue? And this is a really interesting question, because on the face of it, it's an oxidizing, it's a highly oxidative product, and it was surely it's going to kill it. Well, actually, it doesn't. It does exactly the reverse. It actually stimulates production of inflammatory cytokines in the interleukin 6 or the IL-6 pathway. And so what you actually start to see is you see tissue regeneration, and you see tissue and you get nerve damage repair. I'm not quite sure what's happened at your end, but I see the slide. Oh, here you go. Now you've got your slides back up there. And then we started to play with injecting ozone into joints. Because surely if you can actually get ozone into the joint, then you should be able to repair joint damage. And again, this is 2012, and we're actually putting ozone into the TMJ, temporomandibular derangement. And now it's gone on to a completely different area. One of the nice parts about ozone is that somebody decided to take ozone completely out of their comfort zone. There were some interesting studies were done by Giulio Bocchi in Italy, where he was injecting ozone into spine for basically herniated herniated disc and lower back pain. The guys in Toronto came up with a handheld device where it basically produces ozone within that syringe. They inject it straight into the herniated disc area.
Julian, excuse me 1 second. I'm sorry. Before you continue into this new topic, I just would like to ask a question. You mentioned that ozone is indeed an oxidative agent, and yet it does not harm basically healthy tissue, which, I mean, to me, would simply mean that somehow it's selective. It's able to identify unhealthy or necrotic tissue and deal only with that. And I'm just wondering if you could elaborate briefly on that, unless you're going to.
I will cover that a little bit later, but when we get on to talking about skins. But basically, how ozone interacts with the human body. The human body contains factors which will mop up free radicals. So the ozone doesn't actually damage tissue at certain levels. So giving the right dose, it's moving now away from, here's an ozone machine, let's just blast ozone gas into this area or around this tooth. Now we're putting a very precise dose, which is metered, and of a precise concentration into a small joint sac to allow the tissue to repair and regenerate itself. And so ozone has this duality. Giulio Bocchi put it very nicely, and he termed it as the Janus of medical science. It has a bad face, the bad face being the one that it can destroy, and it has a good face in that it can and does accelerate tissue healing, and it can have the most amazing and profound effect on cellular damage in allowing the body to repair itself. So with this duality in mind, provided you understand that, I'm not really suggesting that dentists go off and start putting ozone gas into their patient's spine, but as a part of a medical profession, we do suffer a lot from spinal problems because of the way which we sit, and none of us probably sit correctly over our patients. But the next
Sounds
time
like part of effective ozone therapy is isolation, because I do know that it can irritate the lungs and the eyes. And I mean, to be effective a therapist, as I just said, it's really important that you have the technique so that you pinpoint its application.
Yeah, if I take you, if mentally I can take you back to a slide where you had it was the Helozone handpiece, which had a little plastic cup on the end of it, and the ozone spa, which we're putting a whole patient into. Essentially, it's limiting ozone to a particular area and trying to avoid to get it into the patient's eyes or into the patient's lungs. Having said that, ozone has and was used in the early 1900s to treat patients with TB by inhaling it. So although there are studies that show that ozone is quite damaging to lung tissue and to eye tissue, it is possible to use it in those very fine areas where you don't want the ozone to interact too much with those very fine tissues. Okay, we're moving on now to ozone and dissolving water. It's a quite complex chemistry, as you can see. And the next slide, it starts to show you just how complex the ozone does get, or how complex chemistry gets. But again, you don't actually have to understand this part. You just need to be aware that ozone is a very complex molecule and forms very complex compounds. There are very simple ways of producing ozone in water. So you just put a bubbler into a glass of water and it will bubble away. Or you can use something like what's called a pen cell, which is the proton exchange membrane, where you put water under pressure. And just with 60 volts across the terminals, we can get concentrations of ozone in water up to about 20 to 25%. But what it allows us to do is now to look at a waterline. The dental unit has miles and miles of waterlines in it, and it's probably the dirtiest place in the dental surgery. So some of these early studies, which go back to 2004, 2005, 2006, which is slides which is just about to pop up on your screen, you start to see just how dirty they are. And if you have a practice which is where you treat mainly periodontal patients, you're going to have a very interesting cross-section of these bacteria, irrespective of how well you think you clean your waterline. And if you don't use ozone, here is a really good reason why you should. So the next slide, which is coming up, shows the inside of the waterline. And where the white arrows are, this is what we call biofilm. Biofilm is all the bugs which form this fine sludge around the outside. And once you've got it, it's really difficult to get rid of it, if not impossible. And these bugs, basically this biofilm then breaks off and feeds, so it goes from one area to the next. And for those of you who get occasionally this sort of yellow sludge that comes out of your high-speed handpiece, say on Monday or Tuesday after a weekend, that's the biofilm. But here is just 10 minutes of flushing with ozone. And can you see, you can actually see all that biofilm has completely disappeared. More interesting when you actually start to look at the results is that after you've actually cleaned your waterline, you cannot recover any bacteria and you can't grow anything either from that water. So it probably is the best cleaner system to use. And as a company, and here I'm talking on behalf of my company, which is Graycell Enterprises, we actually make we make a unit which makes ozonated water, which we put into some of the beer lines and soft drink lines in some of our local pubs around here, because it's a very effective way of controlling waterline contamination, which is not confined to just the dental care. It's confined to any place that you actually have a hose or a line which conducts a fluid.
I hope my beer still tastes the same.
Sorry, Danny?
I hope my beer still tastes the same.
Your beer will taste even better because now you don't have a bacteria which are going to cause it.
I'll be able to taste it longer, maybe. Okay. Sorry for the interruption.
No, not at all, Danny. But it's a very interesting point because people do complain of a slight chemical taste for the first couple of times. And what it is, those are the cleaners which are coming through and still contaminating your waterline. So even though you've got a clean waterline, it's still contaminated because you've still got the cleaning fluids there. And likewise, some of the cleaners which we use in dentistry, I would not want those in my mouth. They are really carcinogenic and they will take your living tissue apart. So I'd far rather have ozonated water than anything else than coming through. But the question has really moved on from is ozonated water effective, which we know it is. And the question now in research is how much ozone is actually required and how long of a period do you have to leave it there to achieve inactivation. Again, the research has moved on at quite a pace, and we started to look at MRSA, and ozonated water will disinfect MRSA, and it also will disinfect towelings and contaminated tissues and contaminated equipment from MRSA as well. So if I take you back to that young lady who had the infection on her back after having the tattoo surgically removed, part of the treatment was using ozone gas, part of the treatment was using ozonated water, ozonated oils, and then skin regeneration cream. So it wasn't quite just ozone, but it was a whole complex group of different products which we used to achieve that end result, but still without loss of life and also without regrafting. And we're starting to look at now the ozonated water on soft tissue healing. And we know that ozonated water doesn't produce any deleterious effects or delay the tissue healing. And it's because the ozone comes out of solution, and the ozone actually has a positive effect in inducing the complete reparative and the reparative mechanisms which are found in cellular tissue. We know that ozone will actually encourage and accelerate bone healing. Again, it goes back to accelerating the healing cascade. The second time bomb I'm going to drop into your laps is bisphenol. Bisphenol is one of the dental materials as a pollutant, and they are estrogens. So for those of you who are putting lots of composites in and bonding liquids, which we know contain these products, in the view that they are safer than, say, amalgam, I have horrible news for you. Some of the reduced birth rates in Europe and some of the masculinization of females and feminization of males has been put down to plastics and these types of materials actually found within these dental materials. So I'm not going to go through these in any great depth because I'll allow you to look at the presentation in your own time. But maybe a way forward, if you want to put composites in because you believe it's better than amalgam, and potentially it is to, first of all, get the patient to use ozonated water as a mouth rinse, use ozonated water as part of your treatment protocol in rinsing the patient's mouth before you put the filling in and afterwards, and maybe consider going back to gold. Your patients may not like gold, but as a material, we've never been able to reproduce the effects of gold. Or go down the ceramic, because if you go down the ceramic inlay, you're going to have a teeny-weeny bonding layer rather than a wholesale tooth replacement. And I do believe that maybe this is one area of research where there's a lot more research still to come. But just to put it in context for you, that research wasn't done in dentistry. That research came from the 1980s from farm effluent. And it just shows you that we tend to focus in on central research, and we don't look outside the box to see what else is going on. Okay, we're moving on to treated liquids, which are ozonated vegetable extracts. This is one of the very early studies which we did in 2002, where we took a whole series of commercially available vegetable oils, and we looked to see what were the active components within it, because we were seeing fantastic results, but we didn't really understand it. And that was when we had first access to HNMR, and it really sort of confirmed what we knew from some of the pure chemists, which they had theorized of how ozone interacts with these double bonds. So here you can see this is an omega oil. It's interacting with ozone. You have this carbon-carbon, 3 oxygen atoms. This is the ozonoid. When it comes into contact with water, it then breaks down, and you have hydrogen peroxide and different aldehydes. And that really is the chemistry of why ozonated vegetable extracts work so well. The key is selecting the right oil as your carrier. So the next slide is showing a variety of different plant oils. They each have varying contents of omega-3, omega-6, and omega-9. And myself and another chemist came up with this concept of the POI, or potential oxidative index. That is the number of double bonds per unit volume that you have, or the maximum number you have per unit volume that ozone can interact with. So I know that some of you like playing with coconut because you think it's nice and soft. If you're using coconut, you've got virtually no ozonoids in there at all. Please, if you're going to use some of these oils, go for linseed, or go for olive, or go for safflower, because you've actually got enough ozonoids there that it's going to be useful, and you're not just putting an oil in which potentially is actually no use whatsoever. But if you actually start to look at the percent of ozonoids by H&R, and those of you who know Dr. Eric Zanarski in California, he very kindly did some H&R tests for us and came up with this lovely picture. Now you can see why I like linseed. Linseed is at the top here. It has the greatest number by percent of ozonoids, and that's the active component, and that's why we see such good results. And for those of you who don't believe it, well, here is the research. So we're on the time delay again. That's the comparison between the POI and the percentage by H&R. And then the next slide, which is going to be coming your way, is actually looking at different ways of how people, how these oils are described chemically. And basically, I still think that the POI gives you the best description, because by that you can actually identify which plant oil, how it fits in. If you do the sums, and the sums again are on the slides, and it shows you how to work it out, you can work out for yourself what your POI or the strength, its potential strength is going to be. So it's a nice simple way of assigning, if you like, a value. But if you go again and start to look at the research, there is a huge amount of research out there on how these products have been used and where they've been used. So, for example, we know that Cubans have done a huge amount of research in periodontitis. Again, in Russia, they started to look at subprostatic stomatitis. In Russia, again, tropic ulcers of the lower extremities in elderly patients. And then, again, coming from Cuba right down the bottom, 10 years of using ozonated oil in dermatology. So lots and lots of research. And this is a product which there's a special offer on tonight, and we may have to curtail some of the slides depending on how time, because I see the time is starting to run away with us here, Danny. My fault, because I haven't anticipated the delay in getting the slides from down in South Africa.
Well, I wouldn't say it's your fault, but I think it's something
it is my fault. Don't worry.
Contributed to it.
I'm quite happy to accept responsibility for this. And what I'm going to do is, let me just very quickly, if the computer will allow me, to come out of here. And I'm just going to whiz down a bit, so that otherwise we are going to run out of time. And there's a couple of things which I really would like to share with the audience. So we're going to rapidly move on. Guys, I apologize for curtailing this, but we are going to run out of time. So rather than that, we're going to move on to why I believe we need to start looking at herpes and viral infections and how we can actually treat that with ozone. So there's a little bit of a time delay, so let me just sort of chat to you about this. Herpes and viral infections are important because of the way in which they actually work. And if you start to look at some of the research, and now I've just lost where we were. That's an interesting one. Here we go. That's what I need, I think, to show me where. Here we go. My apologies. I've pressed the wrong button. And Danny, just tell me, what can you actually see on screen?
Right now, we see the PowerPoint, your window that you're in PowerPoint, but everything else is blacked out. I think you got out a presentation probably so you could advance the slides to where you want, which is fine. And with hope, there we go. The screen is rewriting now, And if you get to the slide you want and then press presenter mode, I think in a moment we should be back in business.
I'm already there. I just wanted to know whereabouts.
Then we just have to wait to catch up. These are the challenges inherent in long-distance relationships, folks.
Listen, I've tried that with my wife for quite some time because I was busy. I was actually working in the UK, and then about every 3 weeks I'd fly down here. You know, I did it for 3 years. I'm really glad I don't actually have to do it any longer. But yeah, you know, it can be.
We'll have to stop meeting like this.
Absolutely, something like that. Okay, now.
Okay, you're back. We see research in healthcare, herpes and viral infections.
Okay, great, excellent. Okay, so high-risk HPV virus types 18 and 16, potent modulators of oral squamous cell carcinoma, 2007. You know, this is okay. It's relatively recent, but it's old stuff. Human papillomavirus. Basically, what they're saying is HPV virus, which used to be entirely in its domain of cervical cancer in the women, has now moved into the oral environment. Now, you can hypothesize all you like about what the reason is for that, and there are lots of different reasons. But as a healthcare worker now, we need to get out of this old-fashioned constraint and say, you know, we are now looking at a whole variety of different diseases, which normally we wouldn't have seen. Okay, and then herpes and viral infections. Let me just see where. I'm not quite sure. Oh, that's right. Herpes viral and treating HSV infections. We can use these ozonated oils. This research is not new. In the 1890s, Willoughby Miller proposed that the oral microorganisms in dental cavities played a role in lung disease, in gastric problems, brain abscesses, you name it. And he published that from Miller in 1990. Miller then went on to propose that the majority of systemic illnesses seen in man could be related to the oral cavity. And then that was repeated by a British physician called William Hunter in 1900 when he was doing a series of lectures in the US. And in 1911, Hunter then went on to say that he expounded the theories that he claimed anemia, gastritis, colitis, obscure fevers, nervous disturbance of all kinds, from mental depression to actual lesions of the cord, chronic rheumatic infections and kidney diseases, all had an oral origin. In 1911, Hunter couldn't prove that, but I think since the 1980s and 1990s, I think we've actually elegantly shown that the oral environment is exactly where most of these things stem from, and that's why, for those of you who've ever listened to, say, Chris Kammer and his periodontal program, Gums of Steel, we should have a system like that, which we should roll out, not just in primary healthcare, but throughout healthcare. And dentists need to be really aware that they are the frontline guys who are going to actually look at this and recognize that our patients actually are more than just 32 plus 10 teeth, 32 plus 20 teeth. Okay, and then some of the new research now, which is coming out, this is 2009, 2008, where the published research is actually showing substantiated links from the oral environment and oral periodontal pathogens to Alzheimer's and dementia. You've got Middleton and Petrick, the Lancet in 1980. Again, you know, it's not new research. They were talking about herpes simplex viral genome and senile and pre-senile dementia of Alzheimer's. Dobson and Ektal, simplex herpes type 1, Alzheimer's disease, 1999. Hemling in 2003, herpes virus in brains with Alzheimer's and Parkinson's diseases. The awful statistic is that 99% of the world's population is exposed to the herpes virus by the time they are 6 months old. So we have to live with it, and all of us are probably going to contract it. And because we're now living longer, viruses have much longer time to actually work their not so friendly way on the human brain. But potentially there are ways forward where we can start to use ozone, or we can start to use some of the prion technology to actually undo it. And for those of you who have been looking at the BBC News recently, today there was a very important announcement that a prion has been found which is responsible for Alzheimer's and responsible for dementia. And if we can actually learn how to treat that, potentially we can actually stop dementia and reverse it. So there's some really interesting research which is coming to the fore now. So ozone treatment, certainly in my humble opinion, has really progressed, and it now has an important role in general health due to its unique properties on the effects on bacteria, viruses, and fungi. And so I don't think that any one of us can really afford to ignore where the research is and what the research is showing. And we have to move away from 32 teeth and 20. We have to move to total body health. We have to look at the periodontal status and test it. We know we can predict from a very simple blood test and saliva test which patients are going to be more prone to periodontal disease and oral cancers in the future. So it's really indicative on our profession to actually move ahead. Danny, can you just tell me what you're looking at, please, on the screen, on your screen? Danny? Can you hear me?
Sorry, I was on mute. Research in healthcare, health. It starts in the oral environment.
Okay, that's okay. Okay, right. Because we're basically we are at the end of what you should have. If you can just tell me when it pops up on your screen, it's the picture of the new CMU4, Mark 1 and Mark 2. So one of the special offers for our listeners and for anyone who downloads the program and uses it as CPD until the end of this month. The usual price, or sort of the recommended price and the current price for the CMU4 Mark 1 and 2 is $5,925 US. As a special for the listeners until the end of this month, we are going to give you a discount of $900. So you really don't have an excuse any longer to stay outside of ozone treatment. For those of you who want to have something a little more complicated or a little more complex that you can actually start to sterilize your waiting areas and prevent cross-infection, we have a special offer on the room air sanitizer Mark 1 and 2. The room air, the Mark 1 usually retails at $990. We've taken $100 off that for you at $590. And the RAS2 Mark 2, this is a slightly different version. The RAS Mark II at a predetermined time, which is usually set to about 2 or 3 o'clock in the morning when we hope you've all gone home, switches from a low-level ozone to a high-level ozone output. So it will pump very high concentrations of ozone into, say, your clean areas or into your waiting room, completely sterilize it. You then have a minimum of 45 minutes while the ozone dissipates, that you will have a completely sterile area without the ozone attacking, say, your soft furnishings and your paperbacks and your carpeting. RAS Mark II usually retails at $2,775. The Weathernair Special is taking $500 off for you at $2,295. And the last slide, which I know that eventually the system will catch up, is estimates it for you. So our red hot webinar special offers are CE accreditation through the International Association of Ozone for Healthcare and Dentistry, 6 hours. RAS Mark 1 reduced by $100, RAS Mark 2 by $500, CMU4 Mark 1 or 2, $900 discount. For the ozonated oils, the usual price is $15.20 for each. If you order 10 or more, I'll give you a 10% discount. Please note that these special prices are valid until October 30th, and you can contact me through my email address, and my email address is drjulianholmes@gmail, which is drjulianholmes@gmail.com. I have to apologize to the guys that, and ladies, my apologies as well, that we jumped around a bit. I hadn't, when we did this last week and we did it as a trial, it worked really quickly. I'm not quite sure
Not at all.
why it's very slow this evening, so I do apologize about that.
That's quite all right, Julian. Really, I just want to thank you, and I'm sorry to be jumping in, but your apologies are not necessary. In fact, we owe you a debt of thanks for a really fascinating presentation, and also for the generous offers and for agreeing to share the full 2-day presentation, as well as what I thought was a great job managing these challenges that we encountered today. And before we get to the Q&A, I just want to remind everyone, and I'm talking even faster than usual because we are really up against it here. I want to remind everyone to mark their calendars for the American Academy of Oral Systemic Health's 4th annual session, which is entitled The Gateway to Your Health. It will be in St. Louis, Missouri, September 12th through 14th of 2014. If you're not yet a member, you can join by going to aaosh.org, and if you use the promo code BOBROW, that's B-O-B-R-O-W with a capital B, BOBROW3102, you will get a discount on your membership. And I do know that the agenda of speakers has yet to be finalized. So if you like what you heard today and you'd like to see Dr. Holmes in person, please make your voices heard. The board at AOSH are receptive and responsive to hearing what people value. And I, for one, have and will continue to do so that we have the honor and pleasure of seeing Dr. Holmes in person. Now let's dive into some questions. We got quite a few. I'll try to be as prioritized accordingly. You know, this question was sort of related to the comfort zone poll we asked. And if you can be as succinct as possible, Julian, that would be great. Are there any legal issues? I know you're not a legal expert, and you don't even practice in the United States, but are there any actual legal issues with which you are aware that users of ozone therapy ought to be aware or concerned?
No, I don't. I know the FDA doesn't like it, but then the FDA also accepts that as a clinician, we can choose whatever modality we feel is in the best interest of the patient, and the patient has that benefit of a choice that he can choose or she can choose whatever field treatment she feels or he feels is in their best interest.
Excellent.
What I was going to actually, Danny, there might be another way to manage the question, is that if you send them to me, I'll put them on a slide, and I'll put answers plus research to back my answers up.
That would be terrific. If you just want to say a few words, I know you have a new offering which offers promises hope for people with HIV, and that you've started to use a new oxygen therapy protocol or capsule. Yeah. And if you just want to, maybe we can just conclude with that, and then I'll just have a few closing words.
Well, if you can, in your mind, go back to the picture of the red capsules, we're using that with a protocol plus the use of ozone gas in a capsule plus a rectal insufflation. That is where we put a volume of ozone gas, either from a colonic irrigation or just as ozone gas, into the patient's rectum. The reason we're using a rectal route is because we have direct access into the lower gut villi, which goes direct to the liver. And if we can get the ozonoid and the hydrogen peroxide, which it breaks down, into that area, that's where we see these remarkable changes, and these patients literally get up and they go back to being useful people within their communities. In South Africa, we have an HIV, well, in Africa as a whole, we have an HIV in certain countries which is running somewhere around about 30-35% at the moment. It's decimated complete agricultural communities, and yet we actually have something which is low cost, doesn't kill, doesn't make them ill, and it is a true alternative to retrovirals. For patients who want to use it with retrovirals, it works just as well. But Danny, thank you for that opportunity, and again, my thanks to the listeners who stayed with us through this hour and a half.
And many of them, all of them did actually. They were, I'm sure, only too happy to put up with these minor inconveniences. And I want to thank all of you as well, and ask you to mark your calendars for Thursday, November 21st. At noon Central Time, when we will hear from lead product educator and hygienist Angie Stone, who will share the 5 W's of xylitol and its potential for enhancing the way you practice dentistry. In the meantime, this is Danny Bobrow thanking you for your commitment to practice perfection. Goodbye, everybody.